concerned about how my voice is gonna sound because it sounds annoying.
Mine sounded so
I hate
annoying.
my voice.
Hello everyone, my name is Ryan and I will be going over a case study of an Achilles tendon rupture, and we will discuss how it was surgically repaired and rehabilitated. So if you've never heard of an Achilles tendon rupture, there's been some Achilles tendon ruptures in the news. Most of you girls are familiar with Nicholas Sparks. He was the author. Missy Elliott, David Beckham, Kobe Bryant, and if you're from the Pacific Northwest and you don't know who Wesley Matthews is, please leave the room. Just kidding. Composition of the Achilles tendon. The Achilles tendon right here is a strong fibrous band made up of connective tissue. Fun fact, the Achilles tendon is the strongest tendon in the body. And also, kind of just more information, the blood supply to the Achilles tendon is the most distal tendon in the body, and so a lot of trouble with blood supply runs into this zone right here. And that also comes into play with Achilles tendonitis, tendinopathy, and ruptures. Musculature of the Achilles tendon is formed by the combination of the gastroc and the soleus, and it attaches at the it combines the middle third of the posterior leg, and it attaches down to the calcaneus bone. Bony anatomy. So those three muscles, two muscles, three heads, combine and insert the calcaneus tuberosity again, but here's just a more visual help for you to see that it attaches down to the calcaneus. And also there are two bursa that help to increase movement and decrease friction at that joint. The Achilles tendon functions to help your foot plantar flex, and so when the plantar flexes, the gastroc and the soleus are activated. And if you don't know plantar flexion, if your foot is like this at neutral, your foot is planting down. It helps you to walk, run, and is a vital part of the kinetic chain. It also transmits force from the triceps suri to the calcaneus, and another fun fact, the Achilles tendon force absorbed while running approaches 6 to 8 times the body weight, and so that is why the Achilles tendon, health of the Achilles tendon is so vital to you as an athlete. To present my case is a male, 20 years old, Division III collegiate pole vaulter. He was projected to take conference title this year, and subjective information, when he came into the treatment center, he presented with a friend who was helping to carry him. He could barely bear weight. He had noticeable swelling on the back of his leg and around the ankle joint. And taking objective information, there was a positive Thompson's test. When we squeezed the calf, the ankle did not plantar flex. Manual muscle testing for the gastroc and soleus, because he was non-weight bearing, we eliminated testings of 5, 4, and 3 levels, and we also tried to have him just to activate the calf muscle for levels 2 and 1, and there was no activity, and so we graded him a grade 0. Palpation along the Achilles tendon. Usually, we'll talk about this a little later, or in the next slide about the rupture grading scale, but there is a noticeable divot in the Achilles tendon, and usually it'll be anywhere from 3 centimeters to 6 centimeters, and he had a small little divot along the tendon. He injured himself through intramural basketball. It was not related to pole vaulting, but he injured himself when he stepped off and planted off with his left foot, and he felt a pop in the back of his leg, and it felt like as if someone had kicked him. And so he looked back, nobody was behind him, and he tried to get up, he could not get up, and he sat there for a while wondering what was wrong with his leg, and he needed help to get back to his dorm. So like I said, the rupture grading scale, type 1 is a partial tear. Type 2, which was what our athlete had, is complete rupture with a tendinous gap of less than 3 centimeters. A type 3 is anywhere from 3 to 6 centimeters, and a type 4 is of greater than 6 centimeters. That's pretty major. So the surgical treatment options, you could go with non-surgery or you could go with surgery, and with the surgery route, there are two options. There's open versus percutaneous, and so we chose percutaneous, but the open procedure is they'll have you lying down prone, your ankle will be in a neutral position, and they'll make a long incision along the shaft of the Achilles tendon. They'll pull open it with a clamp and they'll go from either side and they'll suture it back up together. And they'll also remove the blood clot. The cons of this treatment is that there's a larger, more noticeable scar down the length of the Achilles tendon, and because the scar and incision is bigger, there's a greater chance of post-op infection. For the surgical treatment of percutaneous, the pros is that it's a small incision made along either side of the Achilles tendon, and so it's less invasive. And if you think about it, if you've ever seen an arthroscopic surgery for a shoulder, the scars are barely visible, and so that's the pro to this side. And because they're smaller, they're less invasive and less chance of infection. There is a debate from the Dr. Stone Clinic, and throughout my research, I didn't find anything besides what they posted on their own website. But there's a debate about the blood clot, and in the open procedure, you take out the blood clot. In the percutaneous, it stays in because it's minimally invasive. And Dr. Stone's clinic claims that the blood clot provides nutrients and provides healing and stimulates healing and helps the ankle joint after surgery. And so that's one debate of it. But through my research for Tuano and Poon and Seti et al., the research found that early action, which means early range of motion after we take the cast off, after surgery, regardless of either surgery choice, is most beneficial. But for the sake of the athletes worry about post-op infection, we went with percutaneous. So treatment and recovery time, we're looking at a timeline of about 9 months. Kobe Bryant took about 8 months, and there's some websites that will say 4 to 6 months, but I mean, if Kobe Bryant did it in 8 months, Kobe Bryant's Kobe Bryant. He has a different medical staff team, he has different sports med resources, and so we want to be on the safe side. After surgery, he'll be casted for 14 days with crutches. The cast will be a plaster cast, and that'll be in 20 degrees of plantar flexion. And then after we take him out of the cast, we will put him in a below-knee orthotic set at 20 degrees of plantar flexion. I'm not sure if this is what they used in the studies that I found. They didn't have any pictures of their orthotics, but this is a general orthotic set, and as you can see, it can be adjusted to go up into dorsiflexion or down into plantar flexion. It's pretty cool. So the rehab process, for phase 1, our goals of the acute injury phase is to control pain and inflammation. So obviously with any surgery, there's going to be a lot of pain, and because of the severity of this injury, there's going to be a lot of pain and swelling. And so to control that, we want to use modalities such as cryotherapy, ice massage, and also IFC, interferential current, just to help promote healing and promote circulation. For joint mobilization, it wasn't used right away, but we did use joint mobilization to increase range of motion and decrease pain. We used the tail curl technique to improve plantar flexion and dorsiflexion, and we use a subtalar technique to promote inversion and eversion. We talked about counter irritants with the athlete, but personally I don't believe in them from prior experience, and from my research I saw that counter irritants were combined with pain meds, oral pain meds, and so it really didn't have any strong effect on me that they worked or not. And so we warned him about if he wanted to use counter irritants, that's fine, but he decided not to use them as well. And also in the acute injury phase, we incorporated upper extremity cardiovascular exercises so that he would stay somewhat fit and in shape while he was resting. In the second phase of the rehab process, our goal is to repair the athlete's ankle was to reestablish a base foundation to build upon through balance and proprioception, range of motion, and strength. And so the type of exercise that we used was range of motion, passive range of motion, resistive range of motion, balance exercises, a lot of calf stretching, and modalities. One highlight of our rehab protocol was found through the research, and like earlier I said, it was beneficial for early action. So the early action meaning we wanted active dorsiflexion as much as possible, as much as flexibility and pain allowed, and passive plantar flexion. We'd allow the athlete to just drop his ankle as far as he could and do that for his rehab exercises. Another thing, because of Achilles tendon ruptures relation to Achilles tendinopathy, tendonitis sees a lot of great results with eccentric loading exercises. So with calf stretching, we also had calf lowering exercises, and so it was from if you're standing on a higher plane and you're doing your calf raises, you would also go from the top, plantar flex, and just gently go down, and that was your eccentric motion. Finally, for remodeling, we wanted to continue the goals from the repair phase, but also incorporate sport-specific training and plyometric training just to get him fully ready to return to play. We wanted to respect boundaries, but also push the limits, just so that he was ready to compete. And also, we progressed in types of resistance training. We started off slow from a simple air squat, and we worked our way into a full back squat, full front squat. Just things that allowed resistance training and his whole body to acclimate to the increased resistance. Also, we wanted to fix and educate on proper mechanics. That could have played a reason why into why his Achilles tendon may have ruptured, and so we wanted to educate on how to stretch, but proper mechanics means sprint mechanics and part of the kinetic chain when you are in your push-off phase and the drive leg is in active dorsiflexion. This is a picture of your strength progression, but your strength and power progression. But we wanted to progress him from ground zero up to pre-injury levels and even greater. So we went through progressions in balance, cardiovascular endurance, strengthening, and muscular endurance. And in my paper, I kind of outlined how we wanted strength and hypertrophy in the timeline, and also endurance. This is a basic example of some of the exercises that I used for his rehab. Return to play protocol, we want to make sure that he had pain-free range of motion with adequate strength and endurance, both cardiovascularly and muscularly. Being that he's a pole vaulter, he has a short shot of a runway, and it's not like he's using a lot of oxygen to get there. It's a lot of anaerobic motion, but we just wanted to make sure that he was able to fully run down the runway, take his steps, and adequately get himself over the bar. We provided constant evaluations mentally and psychologically. We wanted to make sure that he was ready and he was confident in his rehab and his training and his strengthening exercises, and just in himself in general. After he passed our first two tests, we put him through a simulated competition setting, and we have 5 guys on the pole vault staff, and we put together a little track meet, and our coach is pretty good as well too. So he competed in it, and it was a full-on event. Like, we had heats, we had flights, we had 3 times per flight, and we wanted him to try and win. And also, we wanted to educate him if anytime during an event, during practice, anytime he's not with us, or he's in competition, or even playing basketball, we want to educate him on the risks and what to look out for with this injury. So in conclusion, I do support surgery. I support surgery because it allows the athlete, studies have shown that it allows the athlete to return to play, return to motion at an earlier rate than the non-surgical route would. Also, I fully support the studies that have shown early range of motion is beneficial post-op, and also more education and awareness needs to be put out there for athletes to know how to take care of their bodies, how to strengthen their bodies, how to properly maintain themselves, and the importance of patience in rehab. The number one thing was to return to play, return to competition, but we also did not want to re-rupture. And so in order to properly not re-rupture, we wanted to make sure that he was strong, he was confident, he was careful. These are some of the picture references, and that will conclude my presentation. Any questions? Come on.
So after the casting and stuff, when he was able to do some motions, do you guys have any precautions that the surgeon recommended or anything like that, or was he able to do what was allowed?
So the early action was just as much as he could, but precautions like for infection or just movement.
Just any, like, was he limited in his movement? Like, was he only supposed to plantar flex or dorsiflex in a certain range, or things like that?
Just as much as possible, but with walking, when we finally got him to walk, or when we got him out of the cast, we put him in that heel orthotic. We encouraged him to, so we had him move, but when we progressed him into, I didn't say it in the presentation, but we put him in a walking boot afterwards, and so that, he said crutches, but he was allowed to gently tap just to get him more accustomed to it, and then he eventually moved into that. Any other questions?
What were the criteria for progression from phase to phase?
It was based on pain tolerance. It was based on, we put muscle soreness in there, but I mean, there's delayed onset muscle soreness, and we told him, like, you're working out, you're inactive because of the surgery. It's natural, and so it was just day by day. We just took it day by day on how to progress this stuff. If he thought it was too easy the day before, we cranked it up, and if he was too tired, then we tried to trick him. We tried to trick him to thinking it was easier, and we